In terms of disclosures, I don't have any financial arrangements related to the content of this activity. We'll be talking about contingency management for substance use disorders with a focus on stimulant use disorders. And our objectives are first to understand the foundational principles of contingency management, to explore the effectiveness of contingency management in treating substance use disorders, and also to discuss the implementation challenges and the considerations that are associated with contingency management, which I will just call CM because it's a mouthful from here on out. And I'll say, I can offer the clinical perspective here. I've done CM with in a number of settings. I know people are often very interested in the administrative perspective, and we have some resources for you at the end for those of you who are maybe considering incorporating this in your organization. As usual, I have a lot more information in my slides than I have time to go over, so we'll just kind of hit the highlights, and then if there's anything that would be helpful for me to return to, please let me know. So starting out, what and why contingency management? It's an evidence-based behavioral treatment for substance use disorders. The simplest way I can think of to explain it is just that it encourages positive behavior change by using concrete, previously defined rewards, which we call reinforcers, to increase motivation. Importantly, it can and most often is combined, can be and is often combined with other behavioral treatments that promote broader recovery skill building. So most often it's used as sort of a complement to be able to utilize that enhanced motivation for other approaches. And very importantly, particularly for the population that we all are seeing here in New Mexico, we know that it's especially effective for stimulant use disorder, and that's critical because we really have very few options for stimulant use disorder. As I'm sure you all know, we don't have any FDA-approved medication for stimulant use disorder, and stimulants are increasingly implicated in overdose deaths, often in combination with opioids. So having contingency management with such a robust evidence base for stimulant use disorder, very exciting. In terms of foundational principles, the sort of mechanics of how CM works, the most important to understand is operant conditioning. If you've taken any kind of a Psych 101 course, you've probably heard of operant conditioning in connection with Skinner. He was working in the 30s and 40s to introduce this idea, which at the time sounded really radical, even though it's pretty common sense now, which is that specific consequences can shape voluntary behaviors. We're talking, when we say consequences, about either rewards or punishments. And at the time, he really focused on that division that we can use rewards or reinforcers to increase target behaviors, and then we use punishments to decrease target behaviors. And he was able to apply these principles to develop some surprisingly complex behaviors. If you look up the Skinner box or the operant conditioning box online, you'll see these grainy black and white videos of rats that he taught how to dance and pigeons that he taught how to play ping pong, which might sound frivolous, but it's actually helpful to remember as we talk about it today that recovery, abstinence from substance use is one of the more complex behaviors that we can imagine a human could exhibit. And similarly to the rats and the pigeons, it can be accomplished through CM by chaining together very small behaviors that add up to a very complex sequence. The other thing I'll note that we're coming up on a century out from Skinner's seminal work is that we know now that while punishments do at least temporarily decrease target behaviors, we do know very clearly from the behavioral science that rewards and reinforcement are a more sustainable route to changing behavior. It is much preferred and it's much more sustainable to be able to cultivate a new positive behavior that can replace or fill a similar function to the negative behavior than simply to try to eradicate the negative behavior, which usually will pop back up as soon as the punishment disappears. So that is very much the bedrock of CM is how can we promote and reward positive new behaviors. For a really brief kind of history of where we came from with CM and how we ended up where we are, the first sort of formal CM was Skinner applying those operant conditioning principles mostly in inpatient settings. And that's where we got token economies, which are still used on inpatient units today. And that's about a sort of exchange of, positive behavior for things like clinic privileges. Then in the 60s, this was when behavioral science was just starting to really understand how outsized of a role positive reinforcement played in developing and maintaining substance use disorders. And so they very cleverly realized that that could be harnessed, the power of positive reinforcement, in order to promote sobriety. So sort of using that sort of weapon for good. So they were able to use those principles of operant conditioning to reinforce abstinence and also other behaviors that would compete with substance use. So again, that idea of building up those positive behaviors and rewarding them rather than focusing on punishing the negative behaviors that they were trying to extinguish. And those were best recorded through some early methadone studies at Rockefeller University, where they were informally incorporating positive reinforcement to make the clinic as welcoming and as appealing a place as they could for their population. In the 70s at Johns Hopkins, this was where we first started to see formal integration of CM with other behavioral approaches. So they combined or they applied reinforcement principles for patients with alcohol use disorder and opioid use disorder, and they found improved outcomes across the board, retention, attendance, abstinence, and also building out those substance competing behaviors. In the 80s and 90s, as probably many of us remember, the US was in the grips of the cocaine epidemic, and that really galvanized a sort of renaissance of research into both pharmacotherapeutic and behavioral approaches for stimulant use disorder, and a recognition that the approaches we had were insufficient. And this was when the voucher-based system, which is sort of the precursor of what we now think of as CM, came to be. And that was just where vouchers were exchanged, vouchers being something like the patient could exchange them for something valuable, were exchanged for negative UDS tests. And that was combined with an adaptive form of the community reinforcement approach, which is a behavioral approach that helps patients learn skills around recovery planning. Then more recently, there was a multi-site study, this was in the 2000s, on the motivational incentives to enhance drug abuse recovery. And this was really focused on how to deliver this model in the most economical fashion possible. I'll tell you a little bit later on about the fishbowl technique that was developed out of this movement. But the main thing that they found here that's important for us to know is that they were able to maintain all of those same great outcomes that had appeared in the research earlier, while also saving quite a lot of money in terms of the delivery to individual patients. So that includes improving retention, improving outcomes, and also noting that those lower cost incentives did improve stimulant abstinence for patients who were in the methadone maintenance treatment. So this is where we started to really recognize how key it was for those comorbid disorders. So when we're thinking about the mechanics of CM and kind of what the mechanisms are that underlie it, um, you all medical providers obviously know infinitely more about the physiology of addiction than I do. This is just a 10,000-foot view to get us on the same page for CM. So the idea is that, of course, we know substances of abuse stimulate areas of the brain that we colloquially call reward centers. And when those areas are activated, that very significantly increases the likelihood that the behavior that preceded the activation is going to recur. I know that sounds like an abstract way to put it, but it's important to remember that that general principle, this is a key part of human evolutionary psychobiology, because these areas of the brain are exactly what allowed us to form and maintain the adaptive behaviors that ensured our survival. So behaviors around finding a mate, being able to remain in the tribe, being able to, find food that's nutritious and healthy, and for us to stay healthy. Those are all implicated in those same brain areas. And unfortunately, what happens with substances of abuse is they hijack those same pathways. And this is one of many reasons that people with substance use disorders really struggle with finding the motivation for the things that those of us who do not have substance use disorders consider, what gets us out of bed in the morning, the things that keep us going, those healthy relationships, being physically healthy, meaningful hobbies, meaningful work. Those unfortunately end up being really diluted in comparison to how potent and fast acting substances of abuse are, which are running on those same pathways. Something else to keep in mind in terms of the context, of how substance use disorders develop is that we know that people who grow up in impoverished conditions, not only financially, but in terms of being exposed to things like community violence and just a lack of psychosocial resources, these are people whose brains are particularly vulnerable to substance abuse because they've grown up in an environment that's very poor in what we call natural or pro-social reinforcers. Those things like meaningful, supportive, loving relationships, meaningful work and hobbies, opportunities to, see oneself in a positive light academically or athletically. So when they first get a taste of an illicit substance, it is even more potent because it's landing in this kind of vacuum of reinforcement. So when we think about, how people are showing up at our clinics and what this researcher, this was one of the Rockefeller University researchers, called the state of deprivation, that he says characterizes people, who are at the very beginning of trying to start recovery, where their brain is constantly seeking reinforcement. It's really important for us to meet that with a treatment paradigm that is incredibly reinforcing, what he calls a general culture of affirmation, where patients are going to feel really welcomed and invited into the clinic. So they're feeling pulled into the clinic in a sense rather than pushed into it by less appealing goals. So in terms of how CM fits into these mechanisms, it allows us to give immediate tangible rewards to help resolve the ambivalence that most patients are feeling very early in recovery when they're trying to choose, they're standing at the pathway, the crossroads where, one track is the status quo, which is really easy. The sort of wheels are greased in that direction. They know what to expect. It's going to feel good, or it's going to at least provide relief. And then the other track is kind of unknown, unfamiliar, a little bit intimidating. When we can offer a tangible reward for trying out the new way, that just helps to tilt the decision-making process towards the positive behavior. So it's just kind of putting a thumb on the scale when patients are ambivalent. And this is really important because especially at the earliest stages of recovery, we need something that's more sure and more immediate, because that's where the best learning takes place, from the standpoint of a cognitive neuroscience, is rewards that are right there in front of you and that you get right away when you make the positive choice. So when people are further along in sobriety, that brings its own rewards. They have, improved quality of relationships, more opportunities, better physical health. But those are the kind of rewards that are really pretty distant. They're kind of distal, they're diffuse, they're not guaranteed. And so what CM does is to help bridge that gap between, needing those immediate rewards very early on and getting across that bridge to where, they're sober enough, they have firm enough footing in sobriety that those distant rewards are starting to accrue. And CM just helps reward every step across that bridge. So every small behavior that moves them towards recovery, it's going to help kind of light the darkness across that bridge, so to speak, make it more appealing to move forward. So some of the foundational principles in terms of how it works is that we want to make sure that we reinforce behaviors that we want to see more of as rapidly and relevantly as possible. We know effective reinforcement is positive, it's salient, it's immediate, and with a caveat, it's consistent, and I'll explain that more in a moment. So when you're picking a target behavior that you want to reward with CM, you want to make sure that you can monitor it very frequently, because you want to make sure that it's rewarded as often as you can, as it can be when it occurs, and that you reward it as immediately as possible when the target behavior occurs, because again, we know that's when the best learning takes place, is when rewards are very immediate in terms of proximity to the target behavior. And then, of course, you want to make sure that you remove the reinforcer when the target behavior does not occur. And that sounds obvious, but it can get complicated in practice. When we're thinking of what types of reinforcers work for CM, obviously money is the universal reinforcer because people can just exchange it for exactly what they want. But for obvious reasons, that can be problematic with this population in particular. So usually reinforcers will take the rewards of things like gift cards, vouchers, prizes that can be won out of a prize cabinet. And then also less formally, often privileges. So if you've worked at a methadone clinic, you probably are familiar with extended take-home doses and rapid dosing lines and other privileges that are extended to patients who have demonstrated adherence to clinic guidelines and exhibited more stability in their recovery. And then I also, of course, want to mention social reinforcement counts too. It's the bedrock of behavioral approaches to substance use disorder treatment, as well as, a main characteristic of mutual support groups. But we do know from the research that CM works best when there are concrete, sort of standardized reinforcers. So social reinforcement is important, but it can't be used as sort of the whole system for CM. A few other things to keep in mind in terms of how this is applied is that we want the reinforcer value to increase in tandem with the target behavior maintenance. So in other words, 1 week of a negative UDS is great, and we definitely want to reinforce that. And we also want it to we want to make it a more valuable reinforcer if somebody is able to establish 5 consecutive weeks of negative UDSs, because that is a larger accomplishment in the sense of what we're trying to build towards with this approach to recovery, which is, again, chaining together those small behaviors. We want to make sure that participants understand what the reinforcers are that are available. You want to make sure that everything is above the board and that participants can trust that if they meet the target, that they will receive the reinforcer. And there's no way to overstate how important it is to get feedback from the patient population themselves at your particular clinic of what they would find motivating, because we just find time and again in the studies that well-meaning administrators think they know what's going to motivate patients, but it turns out they are almost always wrong. So I mentioned before that there was this fishbowl technique that was developed to cut costs while maintaining the same outcomes. In fact, there's some evidence that it might very slightly improve outcomes, interestingly. And this is based on the behavioral science of intermittent reinforcement, which is to say that you are rewarding a behavior, but not every single instance in which it occurs. So in this case, what it looks like is a patient being able to, every time they meet the target behavior, draw out of a fishbowl. And usually the way it's set up is that there will be, many, many dozens of what's called just a good job slip, or if it's for a adolescent, maybe a thumbs up emoji. So just something that has no monetary value, but just something that socially reinforces the good behavior. Then there's a bit fewer of the small value slips. So those would be things maybe around $1, like toiletries or bus tokens. Then a few larger ones, maybe around $20, things like gift certificates or phone cards. And then maybe just one, two, or three jumbos, where it'd be around $100. Those could be large electronics, for instance. And the person would get at least one chance to draw, and then maybe more depending on the value of the target behavior that was previously defined. So what they find in running these is that on average, the spending on the patient per individual is around 1 to 200 as compared to 600 with the traditional model. We find that patients not only tolerate this, but tend to really think it's fun and kind of enjoy the sense of anticipation. This is, of course, a population that often has impulsive characteristics, so this kind of manages to harness that in a positive way. And I'll say I've really only had a couple of instances of people reacting poorly to getting one of the good job slips, whereas most of the time, especially if it's a group environment, the other participants will really jump in to say, you did do a good job, and I bet you'll get a bigger one next time. So yeah, that's something that I wouldn't have thought would work so well until I actually saw it in action, but patients tend to really get on board with it. When we think of target behaviors, the best studied are negative urine drug screens, because of course that's the easiest to standardize. Treatment attendance is another really popular one, because of course we know that the more people attend, the better their outcomes tend to be. There are also applications for medication adherence. And then one that is of particular interest from a behavioral standpoint is what's called activity contracting, which is where you identify therapeutic and health promoting goals. So that could be something like if a part of the person's presenting problem was around unemployment, then maybe, the first week the goal is bring in a resume, and, in session we'll go over it together. And if they show up with the resume, then they get the reinforcer. And then the next week is maybe to go to a job interview, and so on and so on. And this is the sort of clearest example of chaining together small behaviors that eventually could result in the person getting a job. So this is one I'll say, if you want to go through these slides later, I encourage you to read this anecdote that illustrates activity contracting. We don't have time at the moment, but I will say I've seen just some extraordinary things accomplished through that idea of just chaining together little behaviors that coalesce into a really large complex behavior. In terms of integration with other treatments, like I said, you can really apply this to any evidence-based approach that establishes goals, because you can just tie the CM to those goals. In terms of formal studies of integration, the best studied is with community reinforcement approach in its adolescent version. So that's where we're using the original behavioral approach, which utilizes functional analysis to help patients better understand their patterns of use and what makes them vulnerable to use, and then combines that with training on how to expand pro-social natural reinforcers in their life as alternatives, as well as recovery planning skills. And that's combined with CM to keep up their motivation in order to meet the sort of sub goals of treatment. And we know that's a very successful model. NIDA published a therapy manual that's specific for CRA plus vouchers for cocaine dependence. That was a real breakthrough for cocaine use disorder. More recently, Impact is an adolescent version that's sort of gaining an evidence base. That's motivational interviewing combined with acceptance and commitment therapy for adolescents with substance use disorders. And that one uses the fishbowl approach. I've done that one. It's a lot of fun. So far, the evidence is showing great clinical outcomes, and also importantly for this population, that adolescents tend to view this therapy more positively than they do most other forms of therapy for substance use disorder, because that's a hard sell with that population, I can tell you. In terms of organizational considerations for implementing CM, one of the things that some of the developers have pointed out is that it's really important to sort of meta-communicate the values of CM, which is to say reinforcing positive behavior. So it's important to be enthusiastic and friendly. It's about creating that treatment culture of affirmation that I mentioned earlier to sort of counter the state of deprivation that many of these patients are walking in. And something that's really interesting about the qualitative literature on the organizational side is that the providers tend to really, really like CM once they are actually doing it. There's often a lot of skepticism up front, and then once they see the results, they're on board, partly because it tends to motivate patients to be much more engaged and to show up more often. So that's a lot more fun of a population to work with. But also something that comes up again and again is that this is particularly effective for what are often called revolving door patients, patients who just drop in and out of the clinic and never seem to get traction. Often these are exactly the patients who experience particular gains once CM is incorporated. So that's a big morale booster for the providers as well. In terms of the evidence, I know we're getting short on time, so I won't go through each point, but the big idea here is that Dr. Voklo, the director of NIDA, she wrote this post where she talks about 5 areas where more research isn't needed to curb the overdose crisis. And I thought this was really well put because we're constantly hearing in emerging areas of research that we just need a little bit more evidence. We need to see it in this population or under these conditions. And what she was saying is with CM, that's not true at all. We have everything we need to know. What she said about CM specifically is in the science to medicine pipeline, there's a point when a body of evidence is so well established that to not put the science into action would be an abdication of responsibility. So just very clearly, we have what we need to know. It's time to move forward with it. And you'll see if you want to refer to this slide that there's a number of meta-analyses showing the superiority of CM to other behavioral treatment approaches specifically for stimulant use disorder, and that the best validated one is a combination of CM with that community reinforcement approach with vouchers. In terms of logistical barriers to implementation, this is where a lot of organizations kind of just don't make it all the way over the fence because it can be really intimidating. One of the biggest barriers is that in most states, Medicaid does not effectively reimburse for contingency management. We do in the last few years have a few states, I think 4 or 5, who have been able to implement the Section 1115 waivers to kind of pilot CM, so to speak, reimbursed through Medicaid for stimulant use disorder, but that's pretty limited, but a good start. A lot of organizations sort of worry about spending too much, and then they end up, it's counterproductive if you try to launch CM and you use too low value reinforcers, and the evidence is very clear on that. In fact, increasing the upfront magnitude seems to actually increase the long-term cost effectiveness, but that's a piece where the translational science often kind of gets lost in application. So of course, we do know costs can be minimized while retaining effectiveness with that fishbowl approach. And then there's a number of other examples, especially around things like sourcing community donations to be able to increase the magnitude of the reinforcers without the organization spending too much money on it. There's also a lot of concerns around regulatory barriers. There was a really unfortunate incident that happened early in the 2000s where some organizations were sort of targeted as they were saying that the CM constituted giving inducements to beneficiaries. And of course, that was settled in court that was of course not the case, but unfortunately that legacy persists, and a lot of organizations understandably are very worried about how they can implement this to make sure that they're in line with the standards. And then, of course, on top of all of that, there's just kind of lack of understanding around what CM is, especially within the context of the stigma of this population, and then being able to properly train the staff and really keep the research to practice pipeline intact. All of the usual kind of problems there, but because this is a particularly technical approach, it's especially salient. Then in terms of ideological barriers to implementation, we do know on the patient side that there's a lot of negative community beliefs that I think are really analogous to MOUD in many ways, where there's this perception that CM doesn't count as true recovery, similar to the language that's often applied inaccurately to people participating in MOUD, that it's immoral to pay substance users for abstinence. I do think most of this is rooted in kind of a misunderstanding of how the model works, but we do, it's easy to see where these concerns come from. And then there's also negative attitudes on the provider and the administrator side, where people kind of say, is this a real treatment? But we do know that once participants or providers and administrators are exposed to training materials and to the evidence, that across the board, their perspective tends to shift to be more positive. So yeah, I'll leave the key takeaways for you because I see we're at half past, and I just want to note there is a resource page at the end of this slide deck. There's a few trainings. I don't think there's one coming up in the immediate future, but this is just a link to mark if you're interested in this, because trainings do periodically come around, many of which are free thanks to SOAR. And then there's a number of materials through the Addiction Technology Transfer Network, training manuals, and also self-guided classes. And then I also wanted to point out that MOUD ECHO a few years ago hosted a contingency management training from an organizational perspective, and we do still have that video in our archive. So if you're interested in that kind of administrative view, I think that's a great place to start. Okay, we're at half past. I'll stop sharing and take a look at the comments. If any of you all have any questions or thoughts, please feel free to unmute. I'm curious to hear what you all think about this.